Typically what I would recommend is when you hold your needle driver, don't place all your fingers in the holes like you would a scissors. That's not going to help you. It's going to make your fingers feel stuck in the instrument. Take your fingers and place them on the bottom aspect of the needle driver, and with your thumb, you can place your thumb in the hole, or you can place it on this part. I usually do within the hole of the upper aspect of the needle driver. I would want you to load a needle at a distance about 60% of the curve, or 60% of this entire needle from the tip is going to be where my needle driver rests, and I want the needle driver to hold the needle at its tip. I don't want you to hold it like that. That's not good. This is how I want it. Some people will put a little bit of an angle to it, but in general, keep it about 90 degrees to the tip of the needle driver. So I have 60% of the curve of this needle loaded. I have the needle at the tip of my needle driver. I only have my thumb in the hole. I don't have my fingers in it. I'm going to assess the surface that I'm about to suture. And what I want to do is I want to hold the needle driver such that the needle rests at a 90-degree angle from the surface I'm about to sew. So with this tissue, I would use this needle in a manner that I entered about 90 degrees from the surface I'm sewing. I use the curve of the needle. And what I'm doing is I'm either going to grab the needle with tissue around it and hold on to it. Let's say if my patient's coughing or moving a lot, and I feel like the needle isn't secure within that tissue, I might hold the tissue right around the needle. If she's very, very comfortable with her cesarean delivery, not moving, not nauseated, a lot of times it's just easier to hold the tissue slightly further from the needle. I want you to re-grasp this, and I want you to curve the needle through using the curve of the needle. Don't fight your needle. Sometimes I'll see people, because they're trying to take a shortcut, and they'll pull it through this way. That's going to bend your needle eventually. What I would do is I would do this, and then to reload it, you can grasp your needle here and then do this. If you're struggling, in obstetrics, we don't typically care if you have to hold on to the curve of your needle to reload it the first few times. When you tie with sutures that have no memory, so our monocrylon, our vicryl sutures, when you tie them, if you loosen, they're not going to stay where they were. Chromic and plain gut that we sometimes use will stay there, so you don't have to be quite so conscious of holding tension on your suture. But what I want you to do is hold tension. I want you to elevate that, bring that through, push down with your index finger. The second knot is typically the most important. If you have any air in it after the second knot, that's an air knot. That's there to stay. So we would cut that about 1 centimeter from the knot. My assistant would follow. Yep. And then what we'll do again, make sure your thumb is where you want it to be. Position this about 1 centimeter from your last stitch. You're going to elevate the tissue 90 degrees to what you wanted to sew. Use the curve of your needle all the way through. Again, here, here, pull it through. Same thing right here, here and here. The pickups you're using should be determined by the surface you're sewing on. So on the uterus, we don't want to use a pickup that is too sharp, or else the point of that pickup forceps will simply injure the tissue we're holding on to. That's a very vascular surface on the uterine, on the hysterotomy site on the uterus. So we typically choose a forceps called a Russian forceps. Yeah. So these are the difference in the ends. These have small teeth, but they're not very aggressive or sharp, and they will hold on to a vascular smooth surface in a more gentle but firm manner without damaging it like pickups with a tooth would. On the non-vascular surfaces, especially connective tissue surfaces, or you do want to use a pickup that has a little more bite to it, like a pickup, a tissue forceps that was either a pickup with a tooth or even a bony forceps that has a pretty substantial tooth at the
big
end.
bony.
Yeah. When you get to the subcutaneous tissues, the subcutaneous tissues are, again, usually pickups with teeth would be used. On the peritoneal surface, very shiny, smooth surface, that would be a smooth pickup. And then on the skin, a forceps that does have a tooth, but it's much smaller and more exact, we would use the Adson forceps.
Okay.
And then just get used to again, holding your wrist such that it is the driving force behind the direction of your needle. And it's not important to me that you take a shortcut and like try to turn your hand weird and pull it through like this. That's not what you want to do. You definitely want to work with the curve of your needle and not against it. It will straighten your needle if you keep fighting your needle. Sometimes when, especially on the fascia, it can be really thick. And so remember, I've already told you can only use 60%. What happens if that tissue is so thick that you can't make it all the way through? You pick up your surface, you load right here, and you get to here, and it just is simply buried to the hub. What you would do is you need to take that in 2 bites, pretend that there's an incision here and not just the edge of this sheet, but you would physically drive it through just 1/2, reload again, and just pick up that other half, the superior aspect of the incision, drive it through. Again, don't fight your needle, use the curve, and you would pull it through using 2 bites rather than 1.